This is Debbie Bucher for Parkland College, and this is the LPN to RN Transitions course using the text by Laura Claywell. Today we're going to be looking at Chapter 16, which is Managing Care in Secondary and Tertiary Healthcare. Also, according to Orem, the overall goal of nursing is to reestablish the healthcare agencies of the patient. The role of the acute care nurse has ended when the balance shifts away from the acute, dependent care needs of the patient. The dependent care agency returns to the patient. Needs can be met by someone with other specific training beyond the acute care setting. Secondary healthcare systems are secondary or acute healthcare uses principles of health restoration and health maintenance. Secondary care is when a need is specialized, around-the-clock nursing care is provided, 24-hour care is needed for this particular patient. Secondary treatment entails prevention of complicating disease, adverse effects, and prolonged disability through early diagnosis and treatment. Tertiary level of prevention entails rehabilitation in the event of disfigurement and disability. It involves health promotion and health maintenance. The outcome priority is to ensure that the patient regains or attains as much independence as possible. So your secondary care is your acute care in the hospital. Your tertiary care is like what a patient would receive in a rehab facility or an extended care facility. Consequence is any significant response to or effect of an intervention. Outcome is an expected consequence of an intervention and can be measured. Side effect, or otherwise known as adverse effect, an unexpected consequence of an intervention. Next, question: a patient had a stroke and has a speech disability. The nurse makes a referral to a speech therapist per the physician's order. Which level of prevention is the nurse using? And this would be 3, tertiary, because the patient is receiving rehabilitation in the event of disfigurement and disability is considered tertiary level of prevention. So environmental influences is prior experience can be a positive or negative influence. Orient the patient to the physical environment of the acute care setting, and implement continuous assessment of the patient's response to the environment. Spiritual needs and influences. Patient may experience spiritual distress. Patients may need a referral. Respect personal wishes and beliefs, whether those are yours or not. And patients may require a spiritual guide or prayer. This is something I think that we forget sometimes as nurses, is that people do have their spiritual needs. We want to make sure that we address this because there's always a hospital chaplain available to speak to anybody, no matter what their beliefs are. So I think we need to be remembering this more so than I think what we do sometimes. So cultural communication. What is the primary language that the patient speaks? Are titles used? Is silence expected? Nonverbal communication is this used? Is touch part of communication? And then under time orientation, is time relative to the situation, or is it strictly by the clock? Is time carefully guarded and are schedules followed? Spatial orientation, is there personal space? What happens if it is invaded? What is a comfortable distance for strangers, caregivers, and family? Social organization, who is in the patient's social circle? Is the person married, have children? Does the person believe in one God, many, or none? What are the person's roles within their social circumstances? And how do political or other views factor into his or her sense of being? Environmental control, where does one's power reside, inside or from outside? What is the person's concept of health and his or her ability to maintain it? Who normally treats illness? What beliefs exist that external forces can heal or cause illness? Biological variation considerations. What genetic predispositions exist? Are there illnesses in the family? What are specific unique characteristics of the body? And what composes the normal daily diet? So carefully attending to these differences and assessment of the phenomena within this model will help to identify holistic and culturally sensitive priorities. And the cultural strain is the tension or pressure experienced by someone who has beliefs tested or when the actions of others are contrary to their beliefs, placing him or her in a position that potentially compromises these beliefs and thus hinders the healing process as a result. So we want to make sure that we are culturally sensitive to our patients that we are caring for. And then again, developmental needs and influences. Acute or chronic illness may threaten developmental tasks. Role strain is possible. Social needs and influences. The patient's social support may be interrupted. Support the family. You want to provide open, honest information about the hospitalized family member as long as you have permission. Anticipate providing updates and other information without the families having to solicit it. Allow access to the patient when possible. And the patient's needs take priority. Visits may need to be limited. There's a time for visitors and there's a time when it's discharge planning is very important. It requires assessing the patient's plan of care to determine whether the outcome criteria are met. Discharge teaching is a component. Occupational and physical therapy may be needed after discharge, as well as speech therapy, and the patients may need extended care if they are not ready to go back into their home environment, or maybe their family members, because the patient is so weak, is not able to provide care for them until maybe they are able to get stronger in order to be discharged home. Discharge planning starts the day of admission, and it is extremely important that we stay on top of things and carefully assess the needs of the patient and the family. Tertiary care referrals. A caseworker may be brought in to make recommendation and assist in making arrangements for transfer to the facility chosen. May refer to hospice if the patient may have 6 months or less to live. Priority of care, patient's peaceful and dignified death after living life. May refer family to respite care, intended to offer the patient's family members time off from their dependent care duties, and also may refer to home health care to provide assistance to the patient and family for a short period of time after discharge to home. So a little bit of information with regards to secondary and tertiary care, and this now ends the lecture for Chapter 16.